So I'll give a brief overview on myeloma kidney. So this is a case that I had from 2013. It's a 77-year-old female. She has really only hyperlipidemia and was noted to have this incidental creatinine of 1.8 on yearly blood work. They told her just drink more fluids and recheck it a month later, and her creatinine was all the way up to 2.8 at that point, at which point they referred her to me for further evaluation. Her only medication, she was on Lipitor and aspirin. Her exam, essentially unremarkable. She looked really well for her age. As you see here in the labs, her creatinine was 2.8. The remainder of her electrolytes were pretty stable. Calcium 10.9, hemoglobin 10.5, and albumin was 3.5. Here's her urine, trace protein, trace blood, no glucose, urine sediment. She had no casts. She had a protein to creatinine ratio of 10.5 grams per gram and a kidney ultrasound that was normal. So actually based on just this information, obviously this is a talk on myeloma in the kidney, but what are the things that are standing out in her presentation that would make you think of myeloma given the information that you have here?
I think with the hypercalcemia that she has,
Okay.
in addition to the anemia as well,
Okay.
the abnormal rise in the serum creatinine also probably represents some sort of renal impairment or renal injury, and also her age as well kind of puts it higher up on the list.
Great. So good risk factors. You talked about her age. This is usually a disease of the elderly. The calcium, the hemoglobin, which are both a little bit high, a little bit low, kind of put you in that direction. How about the urine? How does the urine help you here? What's funny about this urine?
It has normal albumin and the protein to creatinine ratio is 10.5, so I'm assuming it's a non-albuminuric, like proteinuria, so something that's other than albumin that's possibly coming out.
Excellent. So that's the big clue here, and that's really good. So here UA just shows trace protein, and then when you quantify it, you have 10 grams. So if this was albuminuria and like true like nephrotic syndrome, we would see the UA turning significantly positive. So this discrepancy between the UA and the quantification of the protein really was the red flag here that we must be dealing with some kind of overflow proteinuria, production of a light chain that is not dipping positive on the UA. All right, and so we did some further testing. We'll kind of talk about the different types of testing that you can do. I went straight to serum and urine immunofixation, which showed IgG lambda, monoclonal protein in both the serum and urine. And we did serum-free light chains as well. This is before EPIC, so it kind of showed up in what we used to use, a system called ClinDesk. And here you can see the quantification. Lambda is 1,000, kappa is 1, and so the kappa to lambda ratio was really, really like undetectable essentially. So this was a lambda monoclonal protein. And we'll talk about the different types of tests that you can order for myeloma, the indications. We did do a kidney biopsy on this patient. We admitted her for kidney biopsy as soon as we got these results. So before we jump to the slides, if she had myeloma kidney and cast nephropathy, which is what I suspected, what would you expect to see on the biopsy?
We can actually see your presenter view.
Oh, you can. Oh,
I mean, we would.
Okay.
Actually, like,
let me see if I can just share that part of it. Let's see. Now, is that better?
Yep.
Okay. All right. So what would you expect to see?
Fractured casts.
Okay. So fractured cast within the tubules. And so that's what we did see. So here you have a cast and it's kind of got this glassy appearance and you can see these fracture lines across it. And the pathologist will say it's almost like a piece of glass that has been like gently tapped with a hammer and you can see kind of like the breaks within it. Sometimes you get like nucleations of cells within it as well, but this is kind of classic. And then when you stain on immunofixation for these, they should restrict to the light chain that it's positive for. So in this patient, it would be lambda. All right, so what happened is after that, we we asked hematology to do a bone marrow biopsy, which confirmed multiple myeloma. She had 60% plasma cells, lambda light chain restricted. She got Velcade, steroids. We actually started plasma exchange then. We'll talk about the data on that. She never needed dialysis and went home after a week, completed a total of 4 cycles of chemo. And so here's her creatinine. When she came in, she was in the 3 range, kind of peaked at 3.4, and eventually actually stabilized down at about 1.6. She followed with me for like at least 6 years afterwards and did really well. Ultimately ended up dying at home for a completely unrelated reason, and she was, I think, in her early 80s when she passed away. So this was kind of a success at the time, but we'll talk about all the data kind of behind plasma exchange. Here's another important slide, which is the reduction in her light chain. So here you see at diagnosis running at 1,000, and you can see here 3 weeks later, we've already achieved this reduction, and she maintained that reduction. And we'll talk about the role of really prompt chemotherapy being the main driver of this rather than the plasma exchange. But you know, in this case, whether or not plasma exchange had anything to do with that reduction, it remains to be seen, but we'll discuss the data behind it. So it's a plasma cell dyscrasia, which means there's an abnormal plasma cell clone that is making this light chain protein. As Andy mentioned, it's almost not exclusively, but it's a disease. As you get older, it should be higher and higher in your suspicion. There are some weird cases of even like 20 and 30-year-olds having this, but for the most part, as you get older and older, the likelihood increases. Renal insufficiency is seen in about 20% of cases at presentation. And I didn't include this on the slide, but I read a paper once about how about 20 to 25% of all cases of myeloma are actually diagnosed by nephrology because of this finding and because we're checking their urine. So it's one of those things that we have to be kind of on high alert for, and we shouldn't be reluctant to send the testing. So you have an abnormal plasma cell that is making some kind of a clone, and it could be either IgG, IgM, IgA, and it will be either the light chain or the heavy chain, and if it's a light chain, it will either be kappa or lambda. So those are kind of like, you can have IgM, which is also called Waldenström's. You can have IgA kappa. You can have IgG lambda, like this patient. You can even have heavy chain disease. All of those would fall under the category of plasma cell dyscrasia. When we talk about light chains, the ones we were talking about are kappa and lambda. And I think just to briefly understand these, it's important to realize that actually these have kind of a middle molecule size. Okay, so they're not tiny molecules like BUN and creatinine. They're not large molecules like albumin, which are 60 kilodaltons. And so these are in some ways cleared by the kidney. It's important to remember that as your kidney function gets worse, like if you have chronic kidney disease and you were to check light chains, it's not unusual to have some elevation of kappa and lambda. That does not mean that the patient has multiple myeloma or even a plasma cell dyscrasia, because these are normally produced and normally cleared by the kidney. So as we talked about in this patient, there was 10.5 grams of proteinuria, which is a lot. So normally in healthy individuals, there is overproduction of light chains by about 40%. And the kidney is able to filter that and reabsorb that. And only when you are creating so much of this abnormal protein that it overwhelms the proximal tubule's ability to reabsorb it, do you have the protein in the urine. And as we talked about, it's negative on dipstick because the charge of these light chains is positive, whereas albumin's charge is negative. And when we dip urine for proteinuria, it only detects negatively charged proteins. So this is also called Bence-Jones proteinuria when you have this overflow. And this is kind of like the original, I can't believe how old this is now, 1847, like description of Bence-Jones proteinuria. All right. Now we're going to get into like some of the diseases that the abnormal light chain causes. And before we do that, just talking a little bit about why some light chains cause disease and others don't cause disease within the kidney. It has something to do with the underlying structure of the light chain to cause cast nephropathy or to cause amyloid or whatever it may be. When they take free light chains from patients who have myeloma, they self-aggregate a lot more than free light chains from normal individuals. So they're clumpier, they're pathologic. They're not just like a regular IgG light chain. And what's interesting is actually if you take myeloma light chains for patients who have cast nephropathy and you inject them into rats, those rats get cast nephropathy. Or if you inject light chains that are prone to developing amyloid in humans into mice, those mice develop amyloid. So there's something about the structure of the light chain that causes the disease, and it's not so much the quantity of production of light chain. So you can have 10 grams of proteinuria from overflow proteinuria from light chain and not have any renal manifestations. And this is essentially the same thing. Something about the structure causes it to cause the pathology. So maybe it gets filtered through the glomerulus and goes into the tubules, and then maybe it causes the disease within the glomerulus itself, which leads to kind of the different mechanisms of injury. So we're going to talk about the different types of diseases. But here's an example. Like if you have a light chain, and let's say this is a mesangial cell in the glomerulus, maybe it's going to get put into the lysosome and cause amyloid. Maybe it's going to get put into the endosome and cause light chain deposition. Maybe it's going to get filtered through the glomerulus and end up getting into the tubular lumen. Here's the proximal tubule. So if it gets reabsorbed in the proximal tubule, here it could cause a proximal renal tubular acidosis or a Fanconi syndrome. Maybe it filters all the way down into the distal tubule, and here you have light chains filtering in the distal tubule that are aggregating to TAM-Horsfall protein and causing those casts like we saw in that first picture. So each structure of each light chain in every patient is going to do one of these or none of these. And it's hard to predict. Before we jump into the renal diseases, let's talk a little bit about the types of tests that we can order to work up plasma cell dyscrasia. So clearly, chemistry is what we do. Looking for that anemia, looking for that calcium, things like that. We already talked about the urine changes that you could see if you had overflow proteinuria. And now we're going to talk about electrophoresis or PEP, immunofixation, free light chains, and then we'll show some biopsy pictures later on. So when we talk about protein electrophoresis, either in the serum or in the urine, you are basically taking that serum and you're plating it on gel, you run an electrical current through it, and the proteins will separate based on their charge or their size. So this is a very good screening test, but it doesn't really tell you anything beyond that, and there are a lot of false positives. So here's what the interpretation of a SPEP might say in a patient. It'll say, oh, there's a restricted peak in the gamma region, and then you would need to follow it up with an immunofixation. So you may remember here, this is what a normal electrophoresis would look like in any one serum in a healthy individual. The predominant protein is albumin. Then you have alpha, beta, gamma regions, and different proteins are kind of within here, like complement and so forth. Gamma region is where your light chains would be. And so if you had a production of light chains here in this gamma region, it would cause this to peak. And sometimes this has been called the M spike. It does not tell you which light chain, doesn't tell you which immunoglobulin, it just tells you that there's something there, okay? So if you have a positive electrophoresis, you will get an immunofixation, which is essentially trying to identify exactly which protein it is. And you would take a soluble antibody against the immunoglobulin and add it to serum. And if you have a monoclonal protein, it would precipitate out. This is much more sensitive, but it is not a quantitative test. It does not tell you how much. So in a patient where you suspect this, it might come back as this. It'll say, oh, we detected a free lambda monoclonal protein. But it doesn't tell you how much of that monoclonal protein is there.
This is like the mafia. So Democrat law.
Okay. Then you have free light chains. Okay. And here you have essentially quantification of the free light chains. Now, this is kind of like the opposite of the serum immunofixation. It does not detect clonality, but it suggests that you may have an abnormal production through the quantification of kappa and lambda and then the subsequent ratio. So we already talked about in our patient how we had a very high lambda, a normal kappa, and thus a undetectable ratio. So the combination of these three tests is what you want to use. Personally, when I am suspicious of multiple myeloma, I skip the electrophoresis. I go straight for the immunofixation and free light chains. Both of these are cheap tests. They're not cumbersome or expensive for the patient. They come back very quickly, usually within 24 to 48 hours. And so the combination of the serum immunofixation and the free light chains is usually what I do to simply make the diagnosis. That combination has a pretty high sensitivity and specificity. And I don't even bother anymore with protein electrophoresis because I don't find it to be all that useful. It's almost like I'm always going to follow up with protein electrophoresis with the immunofixation of the free light chain, so I don't even bother doing it. Okay, any questions from that? All right, we're going to jump into AKI and renal manifestations of multiple myeloma, of which there are many. And we're really only going to focus on kind of like the big three here in the middle, but you can have essentially any of these. Like these up top, volume depletion, ATN, hypercalcemia, AKI, and chemo, these are actually very, very common. We see these quite a bit. These are the ones where we usually are doing something, either a biopsy or some kind of workup and maybe even plasma exchange. And then there's some more unusual ones down here. We're just going to kind of breeze through those very quickly at the end, things that you should think about. All right, so CAS nephropathy, light chain deposition disease, and amyloid are kind of like your big three. Question from first years, when would you use UPEP? I personally don't find UPEP to be all that helpful. As an inpatient, a UPEP requires a 24-hour collection for whatever reason. UPEP is only, I mean, it can be helpful like if you sometimes might have a negative SPEP because everything is overflowing into the urine. And so if you have a negative SPEP but a positive UPEP, it can be that you're getting rid of all that overproduced light chain in the urine. But personally, I find both SPEP and UPEP kind of pointless. And it seems that I'm always following them up with serum immunofixation and free light chains. So I personally don't do any PEP at all. All right, so when you look at these big three, they actually present somewhat differently on the clinical presentation, not so much the biopsy, but like when you have a patient and you're trying to determine which of these do they have, there are some things that you can kind of use to kind of tease it out. So the big one is patients with CAS nephropathy almost always have pretty severe AKI on presentation, whereas patients with light chain deposition and amyloid has a more chronic, indolent course. And they can have impaired GFR, but it's usually not nearly as high as in CAS nephropathy. The other one here is nephrotic syndrome. Patients who have florid nephrotic syndrome are much more likely to have amyloid as compared to patients with CAS nephropathy. So those are really the two big ones that I'm always looking at. How bad is their GFR? How fast has it gone up? And are they nephrotic or are they not? And then based on those two, I'm leaning towards one or the other. And in the end, it really actually somewhat doesn't make a difference because the treatment is much the same. We're going to talk about how you might consider plasma exchange in cast nephropathy, but the data really doesn't support that. Okay. Cast nephropathy is the first one we're going to go over. We already talked about the fractured appearance of these casts. Here's another one. We talked about the restriction of the light chain. So here is, lambda, and here's kappa, or for example. Here's another nice image. So here you have that glassy cast, fractured, almost like a piece of glass that you hit with a hammer. And oftentimes you can see it here and here, but here you can see the cast has almost ruptured the tubular membrane, and you have this infiltrate of cells within the cast itself. So having this cellular debris there can be helpful and also suggest cast nephropathy. A lot of times it's really hard to tell what's a cast, a myeloma cast versus just like a normal proteinaceous like Tam-Horsfall cast. But that fractured appearance, this cellular infiltrate, and then if they have the cellular infiltrate with these giant cells, that's another big clue. Like this one clearly doesn't look like a normal Tam-Horsfall because Tam-Horsfall shouldn't have cells within it. This is one of my favorite pictures. I think it's just so cool. This is actually a high-power EM of a tubular cast. So we rarely look at tubules on EM, but here's your tubular basement membrane, and this is a myeloma cast within it. And you can really see how it's fractured in glass. It really looks like you just took a mirror and just like hit it, and the whole thing kind of got disrupted. So this is, I think this image will hopefully drill in the fractured broken glass appearance for you. Okay, and then we already talked a little bit why this occurs. So these filtered light chains get through the glomerulus, get through the proximal tubule, go all the way to the distal tubule, and there they aggregate with the Tam-Horsfall proteins. They cause this tubular obstruction, and it's an intrarenal obstruction. And there are a lot of factors that contribute to this: the light chain burden, the calcium concentration, pH, etc. But again, it has something to do with the actual structure of the light chain itself. Both kappa and lambda can cause this, so it's not more common with one or the other. And like I said before, just like the degree of proteinuria does not correlate with the likelihood of cast nephropathy, the degree of casts you see on the biopsy does not correlate with AKI. The same thing can be said of ATN, right? Just you can clinically suspect ATN, and if you did a biopsy and you don't see that much tubular injury, it doesn't mean that it's not there. Okay, how do you treat this? All right, so you're going to do all the regular stuff, like you're going to treat the reversible causes. You might have to do dialysis. Definitely want to do prompt chemotherapy to reduce light chains. And the question now, plasma exchange, hemodialysis, or high cutoff hemodialysis to try and remove those casts. Let me just ask you guys, based on what you know, how many of you would initiate plasma exchange to try to remove casts in the patient patient vignette in the very beginning? Type in the chat either yes or no. I'm just curious. Okay, so pretty universal no, based on studies showing no benefit. All right, that's a good one. We'll talk about the studies here. So this question has actually been around for a very, very long time. Like, I think the first small RCT was like in the late 80s about it. And it doesn't make physiologic sense because because we can remove these light chains with plasma exchange, you need to do several treatments because there is some rebound. So if you start at 100%, after one treatment, you'll be down to 40, but you'll kind of bounce back up. So if you do several treatments, you can remove the amount of light chains within the serum. And if the light chains are pathogenic, which they are, doesn't make sense to get rid of them. And so I think this second point is actually more important, which is that chemotherapy has gotten so much better in reducing light chains over the last 20 years The question is, does plasma exchange do anything else on top of it? This is one of the more recent ones, not the most recent one, but this one came out in like 2005 or so. Not a big study, about 104 patients with myeloma. Not all of them were biopsied, and they looked at this composite outcome of death or dialysis dependence or very low GFR, and really showed only a slight improvement in the plasma exchange group versus conventional therapy. This was not significant, but this was also a pretty small study. And what was really interesting about this study is they did not measure free light chains and monitor free light chain removal. And that's really what you got to do, right? If you are going to remove free light chains, you want to know, are we actually bringing the burden down? And so there was this really fantastic editorial when this paper got published. And from that editorial, someone said, not doing free light chain measurements resembles antihypertensive treatment without measuring blood pressure. So it's a really important point. Is if you are going to do this, you have to be measuring your free light chains to know, are you removing them? So the two big studies that came out over the last 5 years were Meyer and I am blanking on the other one, but we're going to get to it. EULITE. Okay, Meyer and EULITE. So Meyer, again, small study, about 100 patients. All of them had myeloma. All of them had such severe AKI that they required dialysis, and they were biopsy-proven cast nephropathy. So pretty good inclusion criteria, but because of how strict that inclusion criteria was, the study itself was small, and it took 10 plus years to do. So really hard. And then both arms received a modern bortezomib or Velcade-based chemotherapy. And they, because they needed dialysis, they were randomized to regular dialysis or high cutoff dialysis. And what high cutoff dialysis means is that the pores of the dialyzer were large enough to remove light chains. And so they also would need to have replacement just like in traditional plasma exchange, because you're also going to remove albumin and so forth. Their primary endpoint in 3 months was death dialysis, and there was no difference in it, but there was some suggestion that if you looked 6 and 12 months out, that the high cutoff group had improved renal recovery. They're almost twice as high. Again, cannot believe this, but they did not report reduction in free light chain in one group or the other. So here was kind of the Meyer group. This was the, so here's the, between the two, Sana, the question, is the difference between the two arms or the two studies? The difference between, high flux. So high flux is what we normally do. So flux is like how big are the pores. So high flux dialysis is like what we order with regular dialysis. All dialysis now is high flux. What that means is the KUF, or the ultrafiltration coefficient of the dialyzer, is larger and allows somewhat larger molecules to go through. So it doesn't allow large molecules to go through. So when we do regular dialysis, we don't remove albumin, and so we don't have to replace with albumin. High cutoff is basically like super high flux. So the pores are so large that albumin also crosses through, and you remove a lot more of the light chains. Does that make sense? So the high cutoff is almost like plasma exchange dialysis. Okay. So here's the, this was discussed in FJC. We talked about how there might be a possible trend in separating Kaplan-Meier curves over a really long time. But at 3 months, this was really no difference. But if you kind of look out pretty far, 12 months seems to be some kind of benefit in the high cutoff versus the conventional group. Again, this is a study of only 98 patients. So they really couldn't say conclusively that that was the case, and that wasn't the primary endpoint. Here's your Kaplan-Meier curves. It seems like it's pretty much the same. Okay. Here's hopefully what you can to understand Sana's question. So here you have high flux. So no one really does low flux dialysis. That's what they did 25 years ago. Now every dialyzer, like when you order your Revaclear or your Revaclear Max, that is a high flux dialyzer, all right, by default. So you have a KUF that allows middle molecules to pass. Okay, clearance of molecules kind of about 15 kilodaltons. It does take out, you know, a slightly larger, slightly lower. And remember the size of light chains, kappa and lambda, are about 20 to 40. So high flux dialysis shouldn't remove light chains to a great deal, whereas high cutoff dialysis will. Okay, it will clear molecules up to 50. So this is the big difference. Okay. And so if you have questions about the benefit and the adverse effects and so forth, you can kind of refer back to this slide. But basically, when you're doing high cutoff dialysis, because you're removing such larger molecules, you're also going to be losing your clotting factors, potentially going to be losing albumin. So you have to replace all of those things, just like you would with diffusive plasma exchange. All right, EULITE was done in England, very similar in a lot of ways to Meyer, 90 patients. The big difference, so just to remind us what the inclusion were: AKI, severe enough to require dialysis, biopsy-proven cast nephropathy, multiple myeloma. Okay, so those patients were included. And what they did here in EULITE, and the person who was in charge of this was a big fan of doing in-series dialysis. So what that means is, like, you have a regular dialysis filter, and then right next to it, they would go through a high cutoff dialysis filter as well. So in series, so you're almost like doing all of that blood is being cleaned. It's being cleaned, and then the light chains are being removed and moving back. These were also really aggressive sessions, 8-hour sessions, 8 out of the first 10 days in the high cutoff group. No difference in renal recovery in 3 months. No difference in free light chains. They actually did measure them here. What was really interesting is, like, when you do this degree of dialysis and this degree of high cutoff dialysis, you actually remove a ton of light chains. They've done, Colin Hutchinson, who did EULITE, showed some earlier data on the actual amount of free light chains he removes with high cutoff dialysis. And in patients who have a really high light chain burden, he was literally removing like 2 to 3 kilograms, like 5 pounds of light chain over this period of time. So it makes sense. Like, if I'm removing that much light chain, I should reduce the free light chain burden. But what they showed here is there was no difference in free light chain reduction as long as they got prompt chemotherapy. There were more infections in the high cutoff group. So this was prior to publication. It has been published since, but basically showed no difference in the recovery of renal function, about 62% in both groups. And there was, about 50 to 55% reduction in free light chains in both groups because they were both getting chemotherapy. This is from the paper itself, showing that actually the control group, long-term, had better overall survival because the high cutoff group had much more infections over time. And so here's the difference between the two studies, EULITE and Meyer. They're very, very similar in terms of inclusion criteria. They both essentially got good chemotherapy. Here's really the big difference, is the amount of dialysis they're getting. Here in the EULITE, they're getting much more intense dialysis compared to in Meyer. And here they're dialyzing in series. Here they were just getting one high cutoff dialysis. So this is a good summary slide of the two. So you were right, basically, everyone, that the data really doesn't show that plasma exchange adds anything to it, even though it physiologically makes a lot of sense. It's not universally recommended at this point, as long as you can give prompt chemotherapy. And I think that's the most important thing that we need to think about, is when you have cast nephropathy, if you are going to have that patient do well from a kidney standpoint, we need to get those light chains down quick. And the best way to get those light chains down quick is to start them on chemotherapy or have hematology start them on chemotherapy. And that plasma exchange doesn't really add much on top of that if they're getting good chemo. All right, questions on that? Because cast nephropathy is kind of the big question and the one that has the most data. Okay, we will move on. Deposition disease. So usually this is light chain deposition disease, LCDD. If it's heavy chain, it can be HCDD. It all falls under the umbrella of monoclonal immunoglobulin deposition disease, or MIDD. This one does have a slight kappa predominance. So kappa is more likely to cause light chain deposition disease than lambda. It's important to note that a lot of lesions can coexist. You can have this and cast nephropathy as well. Here's what it looks like histologically. So if you remember from our biopsy practice a few weeks ago, we talked about nodular glomerulosclerosis, and that's what we're seeing here in this glomerulus. So these are big nodules, and these are basically aggregates of light chains causing deposition within the glomerulus. You can see these kind of pushing the cells to the outside. Again, if you did immunofluorescence on them, it should restrict in these nodules to whatever clone they have. Same thing if you have this within the tubules. You can have deposition disease within the tubules here, kappa, for example, versus lambda. When you zoom in closely on EM, we already talked about how it's going to affect the tubules, so you can actually see electron-dense deposits within the tubules, not something we're used to seeing. When you look at the glomeruli, sometimes they're called powdery deposits, and so it's like kind of, I don't know, powdery is kind of a weird word because it's hard to differentiate this from other stuff, but these look like unusual deposits. They're kind of subendothelial, they're kind of fine, they're not big and massive like they would be in like membranous. So this is, I guess, the powdery deposits that you're seeing. Here's another image of it. So here you have a glomerulus, nodular glomerulosclerosis. If you look in the tubules, you have powdery deposits within the tubular epithelium. Oh, sorry, no, this is the glomerulus. You have this powdery deposits within the subendothelial space. You have light chain restriction on immunofluorescence. And about a third of patients who have this can also have other organs involved. So we've all done, 7,800 and seen patients who have cardiac issues as well. You could have liver issues. That is not uncommon. And the progression to end-stage kidney disease occurs over a longer period of time compared to cast nephropathy, which is very acute and quite sudden. The treatment is the same as cast nephropathy, which is you got to treat the underlying plasma cell disease and give the chemotherapy. Although there's no suggestion that plasma exchange is of benefit if you're dealing with a deposition disease. I don't know why that is the case, but that has not been studied formally in trials, to my knowledge. All right, lastly, amyloid. We, again, talked about an amyloid case a few weeks ago, but just to back up and think about it. So this is AL amyloid, not AA amyloid or other things which can be also seen. So here, the amyloid fibrils are derived from the light chain fragments themselves. Okay, so the light chains are the pathologic protein that are folding in the mesangium or wherever into these beta-pleated sheets, which then forms an amyloid fibril. So ultrastructurally, and what I mean by ultrastructurally is on EM, you really can't look at an amyloid fibril and say, oh, this is from light chain disease, or this is from beta-2 microglobulin or whatever. All amyloid fibrils look much the same, but there are other clues like immunofluorescence and so forth that might point you in the direction of light chain. So here's kind of like what occurs in the events of the formation of an amyloid fibril. So here you have a precursor, which in this case is a light chain protein. Let's say it's an IgG lambda. It undergoes a proteolytic event, usually within the endosome of a cell, leading to an unstable fragment, which folds and aggregates into a fibril. All right, so they've actually looked at halting the progression of amyloid by blocking these glycosaminoglycans, or GAG. They've looked at medications called GAG mimetics to see if they can block the formation of these precursors to the fibril. And I never actually saw them reported. And so my assumption is that they didn't work. But I know that they were looking at those classes of drugs like 10 years ago. So my understanding, my guess is they were not useful. Again, very similar to before, you can have a lot of extrarenal manifestations. I'd say the big 4 organs that are involved can be the heart, the liver, the bowel, and the kidney. Okay, and then as far as doing a biopsy, because a lot of times patients will have maybe a monoclonal protein, they'll have cardiac involvement, renal involvement, you know, maybe even GI involvement, and they're like, we want tissue to make the diagnosis of amyloid. Let's say we already did the bone marrow and it was negative. Well, here's what's interesting. A bone marrow is only positive for amyloid in about half of the cases. If they have kidney involvement, so if they have nephrotic syndrome and you're really concerned about it, they have a monoclonal protein, you can see here the sensitivity of a kidney biopsy is very, very high. So the general rule of thumb is you want to biopsy the organ that is affected. Now, sometimes you're lucky and you're able to make the diagnosis already on bone marrow, and let's say they had amyloid staining here and they had nephrotic syndrome and you suspected renal involvement of amyloid. Don't necessarily have to chase after it if they were already positive here, but a lot of times if they're negative and you're wondering, do they have amyloid, the kidney biopsy, if is involved, is very sensitive. All right, so same image from a couple weeks back here. This looks very similar to light chain deposition disease. You have this nodule here in the glomerulus. If you look on PAS, you have, again, this nodule here. This tubule also doesn't look normal. And remember, when you're dealing with nodular glomerulosclerosis, either something is there that it shouldn't be, so kind of deposition, or that's collagen, which usually makes you think of diabetic nephropathy. This would be a Kimmel-Steele-Wilson nodule, or idiopathic nodular glomerulosclerosis. So if this is collagen, remember it'll stain really positive, really black on silver. If this is some kind of deposition of something abnormal, then the silver will be negative. So here's your big nodule here. It's silver negative. And just for comparison, this is what diabetes would look like. This big black stain here. Okay, so this would be a KW nodule in diabetes. This would be either an amyloid or a light chain deposition disease nodule on silver. Amyloid needs a Congo red. It's not a routine stain. So at least here, it's not a routine stain. It is at other places. So if you suspect this, you always have to call Joe and say, hey, I really want you to add on the Congo red. And it should stain positive and have this apple green birefringence. Don't forget that the fibrils on EM should have a characteristically small size, about 10 nanometers, 9 to 12 is what is commonly said. So 10 nanometers or so, randomly arranged fibrils is classic for amyloid. All right. Treatment, again, much the same as these other ones, which is that you're going to treat the underlying myeloma. There has been some data to say that these patients actually do better with stem cell transplants compared to non-amyloid patients, although a lot of times if they have a lot of organs involved, like if their heart is involved already, oftentimes they are not a stem cell transplant candidate. So really, how well they do depends on the number of organs involved. And again, I'm just thinking back to my last couple of months on like consult 2 or whatever. It's pretty common that we are seeing kind of the most sick patients. We're seeing patients who have cardiac and renal involvement and have already been given chemotherapy and are doing poorly. I mean, I can think of at least 3 or 4 patients off the top of my head right now that had this. And so those are the patients that are doing really bad because they already have so many organs involved. All right, lastly, we've got about 10 minutes or so left. We're just going to breeze through some of these unusual ones. So cryo, proliferative GN or PGN, MID, MPGN, C3, this should be a 3 there. You can have direct infiltration of the plasma cell light chain thrombi. All right, so here's a cool case. I've never seen anything like this before, but this is a kidney biopsy. And here you have just this infiltrate of plasma cells itself. And so in here, they actually did staining, and it was kappa restricted. And so they knew that these were all abnormal plasma cells. They did CD138 staining. So unusual, but can happen. Oh, here's the CD138 staining, which shows that it was definitely kappa light chains. So C3 glomerulopathy, this is actually becoming more and more understood. Initially, it started out as case reports, but if we ever biopsy someone and they have C3GN, we have to rule out a monoclonal gamopathy in those patients, because monoclonal paraprotein disease is the most common cause of an acquired C3GN. There are also a lot of genetic causes of C3GN, but if you ever did a biopsy in C3GN, make sure you rule out paraprotein, because it can definitely cause that. Here's MPGN associated with it. This is just more like an MPGN-like pattern. All of these come out of Mayo because they have like the biggest biopsy database. Here is actually glomerular capillary light chain thrombi kind of plugging up glomerulus, and here when they zoomed in on it, they actually showed that as well. So there are a lot of unusual causes of kidney disease, but again, the big three that we should think about: cast nephropathy, light chain deposition disease, and amyloid. And with that, I think we're about done. Any questions from the chat? Or you can unmute your mic if you have a question. Okay. I will make sure this is, I'll upload this and give you the slides at some point. So actually, I wanted to ask a question. Anitha had brought something up to me since I have the fellows here. Is there interest in doing a Neph Madness Zoom next week? I would be happy to do it, but I also want people to actually want to do it. So if I know it's kind of a weird time right now, so if people are not feeling Neph Madness, I'm not going to be offended. Madhuri has a very enthusiastic yes. Do people want to do it? Yeah. Okay. Andy says he would do it. Sounds good. Okay. Sana's yes. Yes. Okay. So let me blessings to this. Okay. Good. So we want to do it. Let me think about how to do it. It's kind of challenging to go through the entire thing in like one giant Zoom. What I might do is I might like assign, I don't want to assign too much work, but I might like assign like a matchup to each fellow to kind of brief, so they can read the write-up. And the write-up for each matchup like would only take like 10 minutes to read. And I'll kind of moderate, and maybe you can talk about what you read, what you learned, and what you think should advance based on that, and then that will cover some of it. I know Anitha is going to hop on. She wants to do it. Okay. So it sounds like people want to do it. I will find a date next week, probably looking at Wednesday, and I will send out some information on how that will run. I just have to be creative.
Yeah. Can we do it over a couple of hours? Because I agree with you. 1 hour will not be enough.
Yeah.
Or over like 2 days.
Yeah, maybe let's do it over 2 days. You know, maybe let's do it. Let's see. I don't know what your conference schedule is like next week. Maybe let's do it on like Monday and Wednesday or something like that. If we did it,
I think Dr. O'Brien will know the conference schedule.
Okay, I'll talk to Frank and ask him what work. He had asked me to do something on Wednesday, so maybe I'll do another day earlier than that, Monday and Wednesday, and then I agree. That way we won't rush through it as much, and I can present some slides. And then if you're interested, actually, if you want to just like kind of get a head start on it, tonight's NEPHJC is going to be a Neph Madness discussion. We're going to have just like polls of like the different teams. You're going to kind of see how other people vote based on what. So if you want to tune in at 8 p.m. tonight, NEPHJC, it'll be a Neph Madness discussion there, and we'll kind of get a head start. And then I will plan on doing some kind of Neph Madness thing next week with you guys.
Great.
Sounds good, all. Thanks for coming.
Thank you.
All right. Bye.